All right. Hello, everyone, and welcome to Elevating Image-Guided Risk Assessment for Proactive Cardiovascular Prevention. My name is Dr. Chuck Vega. I'm a clinical professor of family medicine here at the University of California, Irvine, and it's really delightful to have you along for a very important subject and a dynamic presentation that we have in store for you today. I'm delighted to be joined by two wonderful colleagues, incredibly knowledgeable and who have actually become real leaders in this field of cardiovascular prevention. First, we have Dr. Deepak Bhatt, and he is out of New York and at the Icahn School of Medicine and one of the leaders in cardiology there. And then he is joined as well by Dr. Mike Blaha, Associate Professor of Cardiology and Epidemiology at the Johns Hopkins Chickaroni Center for the Prevention of Cardiovascular Disease in Baltimore, Maryland. Welcome to you both, and thanks for being here.
Really great to be here.
So Deepak, do you want to get us started with some basics here?
Yeah, sure. Let me kick things off a little bit. As the slide shows, there's a binary approach to prevention right now where people talk about primary prevention and secondary prevention. There are some folks that talk about primordial prevention. That's trying to prevent risk factors from developing in the first place. But primary prevention in general refers to treating risk factors. Secondary prevention refers to treating disease. That's a bit of an artificial separation in reality. But in general, if people are asymptomatic, even if they've got a bunch of plaque in their arteries, they would fall in the primary prevention universe. Whereas if they have plaque that perhaps is the same degree of plaque, but they were symptomatic or had some testing, either appropriately or inappropriately, ended up getting revascularized with a stent with bypass surgery, those sorts of folks would be secondary prevention. But so you can see there's potentially a lot of blurring between these two. You could, in fact, have greater plaque burden and still be in the primary prevention part of the universe than someone in the secondary prevention. So very artificial distinctions, but that's what underpins our guidelines for prevention, whether someone's primary prevention or secondary prevention. That affects the intensity of the guideline recommendations for things like LDL control, other risk factor control. So right now it is an important construct because it guides us in terms of what to do. But the real question I would pose to the audience is, in the future, is this the best way to figure out who should be allocated different forms of medical therapy? And it is a continuum of risk. Indeed, there's folks that probably you could say just have some risk factors and deserve to be in the primary prevention universe. Maybe cholesterol is a little high, but no evidence of atherosclerosis, even if one were to look. And I'm not saying to look, that the data supports looking right now, but let's say one look, there's no atherosclerosis, LDL is a little high. That's probably really primary prevention. Try to keep that LDL from getting higher, intensive lifestyle modification to keep risk factors from progressing in severity or in number. And then secondary prevention, if somebody's had a heart attack or a stroke or a revascularization procedure, has clear-cut angina, symptomatic, that's probably clearly in the secondary prevention universe. But there is this group, the middle group as depicted on the slide, I'd say rather a large group of people where if you happen to look, they would have advanced subclinical atherosclerosis. So that's the sort of patient where if you happen to get a carotid or femoral ultrasound and saw a lot of plaque, but they're totally asymptomatic, well, are they still primary prevention or are they now secondary prevention? Or if you happen to get a coronary CT angiogram, and I'm not saying to do that in someone that's asymptomatic, but let's say you did, and there was a bunch of plaque, where would they be binned, in primary or secondary prevention? So that's really the dilemma.
Yeah, that's such a great point. And it's really where we're at right now with this blurring of the lines between primary and secondary prevention, particularly when you think of disease progression, not just risk factors, but the actual staging of the disease. So there's really so many ways we could try to improve this risk paradigm. Instead of just risk factors or secondary prevention, we can see in the slide, plaque is a continuum, of course. So on the left is sort of the traditional approach, primordial prevention, risk factors, primary prevention. But as you can see, there's so many things like behavioral factors, genetic factors, environmental factors, imaging, biomarkers like serum biomarkers or genetic markers, all that could improve and try to put someone on this staging paradigm. But of course, many things we don't have great data for or emerging, or certainly not routine practice. So if we go to the next slide, what is sort of routine practice now? Well, we're in still the traditional risk factor paradigm, right? We've used the Framingham risk score, we've used the pooled cohort equations, and now we're on to an improved risk score. But really, it's in many ways similar to the approach of prior risk scores. The PREVENT equations still use traditional risk factors largely, but you can add social determinants of health, a hemoglobin A1C, or a urinary albumin-creatinine ratio, UACR, as well, to project out over 10 years or even 30 years the risk of an atherosclerotic cardiovascular disease event or heart failure. But you can see, once again, this paradigm still doesn't include this kind of staging concept of how much disease does the patient actually have. It's an improved risk score, but it still relies on those traditional risk factors we measure one time in the clinic and try to arrive at that risk. So the question we're going to pose today, for example, are other modalities like imaging helping us to put patients on this continuum of risk that might have distinct treatment indications, treatment implications. So one way, of course, you can do that is the coronary artery calcium score test. What is the calcium score? The calcium score is a routine, non-contrast, cardiac-gated CT. It can be done in a couple minutes at about 1 millisievert of radiation. And the idea here is to try to detect calcium within the coronary arteries that's directly reflective of the total burden of atherosclerosis within the coronary arteries. So, for example, if you did a calcium score and the score was 0, the person wouldn't have much or any coronary atherosclerosis. And if the coronary calcium score was high, they would have a lot of atherosclerosis, more like those patients that Dr. Bach mentioned that are more like secondary prevention. If you go to the next slide, the guidelines are already starting to endorse the calcium score for limited patients to try to stage them or risk stratify them. It says in intermediate or borderline risk patients, the decision, for example, about statin use or really risk in general is uncertain. You can use the calcium score to withhold therapy, postpone therapy, or be aggressive and initiate therapies to potentially do maximal risk reduction. But of course, there's many other ways that you could detect atherosclerosis, and many places around the world, ultrasound is preferred over cardiac CT. So there are ways of using simple carotid ultrasound, not just to look at the stenosis within the carotid artery like we might for a Brewy or something like that in the workup of stroke, but to use ultrasound to actually determine the burden of carotid plaque. So you can take a carotid ultrasound of the left and right coronary arteries, divide that carotid artery into the 3 segments, near and far wall on the left and right side. Depending on how much of that carotid artery is afflicted by plaque, you can come up with the carotid plaque score. Much like the calcium score, the carotid plaque score reflects the total burden of atherosclerosis and predicts risk very well. But there's other ways too. So go to the next slide. As Dr. Bott mentioned, CT angiography can also do the same thing. We know that the more atheroma volume you have within the coronary arteries, the higher risk you are. And this particular paper talks about sort of staging of atherosclerosis, absent stage 1, stage 2, stage 3, as coronary atheroma progresses as detected by CTA. So really, we talked about the calcium score, the carotid ultrasound, and the coronary CTA, really, but just the principle is that the more atherosclerosis one has on an imaging test, the higher risk the patient. And does this challenge that paradigm of primary and secondary prevention?
Well, that's a great question, and one we really need to sort out. And very recently, a trial was launched, the Transform trial. And this is a study that essentially is looking at guideline-directed therapy versus a more intensive form of medical therapy that is titrated by the coronary artery disease stage as assessed by a coronary CT angiogram. So this trial, Transform, overall will consist of about 7,500 patients that have diabetes or prediabetes or metabolic syndrome, but no symptomatic cardiovascular disease. So what I would call, sort of medium risk primary prevention. And there are really 3 trials embedded in one. One trial is Transform Classify, where our intent is to see whether getting in the investigational arm a coronary CT angiogram is better than just using any of the different risk scores that are out there, like the AJACC risk calculator, for example, maybe newer risk scores like PREVENT, and just see which is better, actually looking to see if there's plaque or using these clinical risk predictors. So that's transform classified. Then there's transform plaque, because actually in the investigational arm, there'll be a coronary CT angiogram performed at baseline, but also one at 2 years. So the goal will be to see, will there be progression of plaque? And if there is progression of plaque, is it slowed down in the investigational arm by an intense medical therapy? In the control arm as well, there actually is a CT coronary angiogram at baseline at 2 years, but until the end of the study, everybody's blinded to that. So at the end of the trial, it'd be possible to say, okay, if you just do what the guidelines do, what happens to the plaque? Does it progress or not? So that's transform plaque. And there's transform outcomes, which is a really aspirational embedded trial where we're seeing in these 7,500 or so patients whether this strategy of staging coronary artery disease based on a coronary CT angiogram and then titrating the intensity of medical therapy is better than just doing what the guidelines would have said in terms of LDL and blood pressure and other risk factor control. And there the idea is to see, is there any impact on cardiovascular events? And if the answer is yes, the hope is that would redefine primary prevention and we would stage coronary artery disease the way that cancer doctors stage cancer and titrate the intensity of therapy based on the stage. And if that part is negative, then it would mean for healthy people that are walking around, just treat the risk factors like we do now, but no need to actually go further and image. So that, in a nutshell, is what the trial or trials are intended to do.
So it's pretty amazing, and thank you for that wonderful review. That we have known science now with the equations. Perhaps getting a little bit tighter and prevent should help to move more folks off of more aggressive therapy as predicted, as that becomes more widely adopted. So less use of statins, maybe lowering the rate of multiple antihypertensive drugs, so reducing that burden on patients. But at the same time, I think it's those tools are only even the coronary calcium score or an ultrasound are only as valuable as how you implement them in your discussion with patient about what you actually do with these results. And I think it's important, and we have some cases coming up that will cite a couple of patients who one is a little bit more passive, one who really wants a more aggressive approach to cardiovascular prevention. And then I think it's important for all of us as clinicians to take our own biases into account. I tend to be a lot more aggressive in my population, which suffers disproportionately, not just from cardiovascular disease, but for all the risk factors for cardiovascular disease, the big ones being obesity, in my practice, diabetes, hypertension, dyslipidemia. So I'm very much, I know that I'm already a statin hawk. I tend to follow guidelines that are more aggressive from the American Academy of Clinical Endocrinology. And so just to set it straight for us in primary care out there, those guidelines would state that if you have a patient with type 2 diabetes and at least one other risk factor for cardiovascular disease, your goal LDL is not less than 100, it's actually less than 70. If you have chronic kidney disease in of itself, that's a cardiovascular risk factor. You want that goal less than 100. And if they have CKD and type 2 diabetes, along with existing cardiovascular disease, your goal LDL per those guidelines, and this isn't the one and only, but it's something that I tend to believe in, that goal is less than 55. So I think that one way it's going to influence our thoughts is how we apply those lipid lowering therapies, not just statins, but we have other therapies. Do patients, could they get two lipid lower therapies at the same time? Absolutely. Sometimes that's necessary to get patients to goal. And as well as aspirin, which I'm going to cover here in a second, because that's a little more controversial, and where I've tended to be more aggressive with statin use. I've become less aggressive with time with aspirin for primary prevention. Remember, we're thinking about primary prevention here. Once there is that, I know there's a continuum, but once there is established disease, that's a different story. And then using more kind of like what we were just describing, that when you have more risk, wouldn't you want more help? And that's where, especially if the patient has type 2 diabetes, GLP-1 receptor agonists, SGLT2 inhibitors, they're coming into play a lot more sooner, earlier in care, to hopefully prevent that atheroma volume and prevent those cardiovascular events. Aspirin, as I mentioned, is an area of some controversy. And there were 2018 was a really tough year for aspirin's primary prevention trials with the spree, where there was a higher risk of mortality associated with the routine use of aspirin versus placebo. But one thing I think that for our folks in that recommended range, which is now 40 to 59 years of age, where we could consider using aspirin as primary prevention therapy, that's probably where it's going to have the most benefit per clinical trials. And really what we're looking for is a balance between cardiovascular protection and the risk of bleeding that we know comes with aspirin. Even at a low dose, and even in younger adults, aspirin is associated with a higher risk of bleeding. Now, and it comes down a lot of times to shared decision making with my patients. Given the results of the ASCEND trial, this is something I talk about with my patients with type 2 diabetes on a routine basis. I do put them in a risk calculator to assess their overall risk of cardiovascular disease. And then we talk about the risks of potentially saving them from potential heart attack or a stroke versus the risk of hemorrhage, most of which is GI hemorrhage, but there are rare cases of intracranial hemorrhage as well. So that comes down to their baseline. And so it's a balance, cardiovascular risk versus bleeding risk. And we want to take those things into account. And what really makes a difference for those folks is their personal beliefs and preferences. So I want to elucidate those during the clinical visit, because that at the end of the day has a huge sway in my decision as to not just to initiate therapeutics, but if I'm going to go back and order a carotid ultrasound or a coronary calcium score, I really want to know it's actually going to make a difference, and talk to my patients about, would they be accepting a therapy that's more aggressive or less so based on those values. So I think that's where it plays. These really exciting modalities play into primary care.
Yeah, you make some really good points there. I think in general, of course, more aggressive treatment for the higher the risk, that makes sense. Shared decision making. And particularly, we need to be thinking about the net benefit of therapy as a function of risk. So bringing this all together, just as you said, where aspirin is one of these questions where we have to balance the benefit with the risk. Here's where this issue of primary versus secondary prevention, or that blurring that we've talked about, really comes into focus. So this was a study where we looked at the calcium score. We projected the benefit with aspirin therapy based on as a function of the calcium score. So in the bars is the number needed to treat to prevent one event with aspirin over 5 years. And the red line is the number needed to harm. What you'll see here is in the blue, if you don't consider a tool like a calcium score and just use a traditional risk score, it's hard to find patients that clearly benefit from aspirin, because the benefit and the risk both go up with traditional risk factors. So in the blue, generally speaking, is at or above the number needed to harm line. Likewise, if the calcium score is 0 in orange, we can clearly see that the number needed to treat is much greater than the number needed to harm, telling us, hey, if we're treating our patients with no plaque with aspirin, we're probably going to do net harm. Now, in contrast, you can see in green when the calcium score is above 100, or in dark green when it's above 400. So these are patients with moderate to severe subclinical atherosclerosis. They clearly have a net benefit of aspirin compared to the expected risk of bleeding. This is in patients less than 70 with no clear history or high-risk features of bleeding. So this is the general primary prevention population you can see in green. So this is what we're talking about here. Can imaging tools define a middle group of patient between traditional primary and secondary prevention, where the number needed to treat is much less than the number needed to harm, and we can say, we think you're going to get a net benefit from aspirin. And you can take this further. It's not just the calcium score. It's things like carotid ultrasound too. So in the next slide, we have a recent analysis that looked at the same sort of question, but using carotid ultrasound instead. So if we go to the next study, this one first from both Mesa and Eric, sort of the same presentation here. And we can see that, once again, if you use just risk scores in the dark brown on the left, the risk and benefit of aspirin is pretty much balanced. If you don't have any plaque in your carotid arteries, in general, you're going to cause more bleeds than you'll have cardiovascular benefit. But as the carotid plaque score went above 2, and at least you have 2 segments of the carotid arteries in the bilateral carotids that have plaque, you start to see net benefit. And the more carotid plaque, the more benefit. So I think this is sort of where we're headed. The more plaque you have, the more benefit you get from aggressive therapy, particularly in intermediate risk groups. That is where we have a lot of uncertainty, and where this idea of the middle ground staging of atherosclerosis may come into play, where therapy like aspirin that can cause both benefit and harm.
Okay, so now we're going to take a couple cases with our experts here to try to tie some of these themes together. So we're going to start with a 48-year-old man referred to the Brigham and Women's Prevention Clinic for a high coronary calcium score. Turns out he's a former smoker with prediabetes, eats an average American diet, and he's uncertain about his family history of coronary disease. I see that a lot in my clinic. It's hard to peg down exactly what happened and certainly what age. Blood pressure 132/87. His HDL is low at 37. His LDL is at 101. And we put him through that prevent risk score calculator, and he's got a 7% approximately 10-year cardiovascular risk, along with 27% 30-year cardiovascular risk. When we think about Mr. Sanchez, guys, what do you think about his score? Or what would you think about how you might approach him? Is he kind of in that middle group to you?
Yeah, I would say, we're yet to learn kind of exactly what risk groups are going to fall out from this prevent risk score. But clearly, I think by any measure, he's in the middle, right? He's not very low risk and he's not very high risk. This is the clinical conundrum we see all the time, right, Deepak, where the patients ask, well, what's my risk? Is it low? And you say, not really. Is it super high? Well, not really. And you have a hard time saying what to do next. So, what do you think? I mean, isn't this sort of standard patient that we see that we have a little uncertainty about?
Yeah, actually, I think these are really tough patients because if he came in with a history of heart attack, well, obviously there is a right thing to do. Maybe he's statin hesitant or any number of practical issues, but obviously he should be on a high intensity statin. And, if the person's really young, zero risk factors, feeling great, probably you just want to tell him eat right and, try to stay out of trouble, exercise. But here in this intermediate zone, it's really hard to know what to do with the information here. If you surveyed 100 prevention experts, 50 would probably say, yeah, go ahead, start a statin. And the other 50 would say, oh, the LDL is 101. That's basically close to what the guidelines would say anyway for primary prevention targets. It's almost under 100. So, there's a lot of latitude what one would do here if there's no other information. So this is probably a situation where if you want to be objective about what you do, you try to get some more information.
Yeah, and I think that again, this is where getting more information. I agree, it's a great case for that, and we do have more information. I would just make sure I get Mr. Sanchez's buy-in on this beforehand, because if your coronary calcium score comes back elevated, we are going to move towards a statin. So I define the plan before he even goes. Whereas if it's really low, we probably won't go forward with a statin. That will, maybe he has that high fear of statins, or maybe he really wants one because his brother, his sister, their uncle, everybody else in his family's on one. He's very nervous without one. Is that a reasonable approach to get that buy-in before referring for a CT?
Yeah, I think so, because you shouldn't order a test if it's not going to change management. I mean,
Yeah.
it's true that the radiation exposure is pretty low here. There's really little risk. The cost isn't particularly high. But on the other hand, there's some finite amount of radiation and cost. So we won't just do tests for no good reason. So a great point. Yeah, got to make sure the patient is going to find the information actionable, that the doctor is going to actually find it actionable. Otherwise, why get it?
And could one of you jump into the idea of coronary age? Because I think it's a great descriptor. Instead of, I left the comments like, is it really high risk? No. Is it really low risk? No. But coronary age really, I think, makes it, I think, a lot more palpable for patients to understand.
Yeah, what was shown here is, of course, the calcium score came out high. It was over 100 in this case, the 93rd percentile. But to put that in even more perspective, with the MESA study, there's a way to translate that patient's risk to a coronary age. They have the age of a healthy person of another age. Now that we know this patient's calcium score is 110, they actually have the risk of a healthy 74-year-old. And sometimes patients, that makes that connection with them to make actionable changes in their life. And they realize that, indeed, might have a higher risk. It's actually more like maybe my parents or something like that. And if his calcium score is 0, his coronary age would have been 46 in this case, despite the risk factors. So we can see that there's disparate ways of going forward, statin and aspirin or other therapies too, based on the results of this test.
Yeah, the CAC data you presented, I thought, was really interesting. Of course, it is observational. Ultimately, it's not randomized assignment to therapy, so a little caveat there. But nonetheless, it makes intuitive sense. And, this patient does have plaque, we can assume, given that the CAC score is 110.
Yeah, and would that change, if you had a carotid ultrasound with a plaque score of 2? I think we're kind of
Be very
still.
comparable. Yeah, very comparable.
Mhm.
Moderate atherosclerosis in 2 beds. Yeah.
All right.
Yeah,
So
I
let's
would
let's
agree.
So let's move on to our last case now, as we start to kind of get near time here. I'm hoping we have a couple minutes for questions that have come up, but if not, we'll just do a discussion. But let's start with Mrs. We can't forget about Mrs. Roberts. She's counting on us to see her today. 55-year-old woman referred to the Johns Hopkins Cardiometabolic Clinic for risk stratification. No smoking history, no hypertension or diabetes, good diet and exercise. She has a family history of premature CAD in her father. It'd be good to know exactly when he developed CAD, and she's motivated to take preventive therapy. I've already alluded to the fact that that's pretty important. BMI is 27, blood pressure 126/78, HDL is great, 60, and LDL is 145. Pooled cohort equation for her demonstrates a 3.8% 10-year cardiovascular risk. What is your initial impression of Mrs. Roberts, guys?
Well, I'm always worried when there is sort of a four-man genetic test of premature coronary artery disease. So that always makes me a bit nervous.
Yeah, good point. So maybe we could, so she's someone where we might think about doing some extra testing. And so let's show that now, because yeah, that is a concern. And lo and behold, we have, a part of the lipid profile, which is very much related to genetics, which is the lipoprotein little a, elevated in this case at 255. But we also took the time, because she is very motivated and very concerned, justifiably so, that we did that coronary calcium score, came back at 0. So now we put her, with this in mind, seems like she'd still be in a fairly low risk group. Is that correct?
Like I said, this is so important with shared decision making, like you mentioned, to talk to the patients about their risk and decide where they want to go. That first patient clearly has got advanced subclinical atherosclerosis, probably going to consider a statin and an aspirin and be intensive. Here, we're going to be able to be flexible, right? The calcium score is 0, but there is several other markers of risk. We'll talk about this patient very differently. Their stage of their coronary disease is very different, but they have some long-term risks. So we're going to have to talk about lifestyle and or maybe less aggressive, but preventive pharmacotherapy too. So I think this is a great demonstration of how both of these patients, before we did the testing, maybe you would have thought were sort of similar, but actually after testing, they both look sort of different. And you talk to them in different ways, but both of them still need to be talked about different ways of lowering risk.
Yeah, I don't know if you could hear the fire alarm going off here in the hospital, but I guess I would be alarmed about this patient. I mean, the CAC score being 0, is reassuring on one level, but that family history of premature CAD, the LDL of 145, and LP little a of 255, would still make me nervous. I don't know that LP little a risk is fully captured at this point in time. We know from the epidemiology it's a pretty potent independent risk factor. Trials are ongoing to see if directed therapeutics do or don't reduce cardiovascular risk. But I'd be a bit nervous about her, and obviously would tell her to watch her lifestyle and do the right stuff that way. But probably would be inclined to start a statin on her when I see that LP little a.
And again, adding the carotid plaque score here, again, somewhat reassuring. But
Yeah, just
still
you've
with
got
the
some
LP.
early plaque. I think that the distinction here in the cases is this person's a little earlier in the staging of atherosclerosis, thinking a little more about lifetime risk. Lipid-lowering therapy makes sense. Maybe not an aspirin in this case. For example, in the other patient, advanced atherosclerosis, aspirin probably makes a lot more sense. That's the thing. Even the statin and aspirin decisions might vary according to these results. So yeah, I agree completely. You have to talk to this patient about her long-term risk, probably lower her lipids. I probably wouldn't start an aspirin in this case. Probably would in the other case. But these are decisions that you have to make every day with the patient.
Well,
Yeah, totally agree.
yeah, that was a great discussion. I think we go to takeaways, and Deepak, just an outstanding job of actually engineering the alarm to demonstrate your alarm. Somehow you managed to actually have the whole building go in an alarm mode, which was
Well, look,
that's
atherosclerosis is alarming, even if it's silent
Yes, it is.
atherosclerosis.
I think we have a take home from today, but let me try to add to it. So I really believe in the pool cohort equations, or just using some risk stratification for adults 40 to 75 years of age, particularly really helpful. Prevent equation may help to reduce the application of statins as primary therapy, which would be really interesting to see how that plays out over time. We talked about that broad middle. I agree. There's a lot of my patients in there. Using the coronary calcium score, using carotid ultrasound can be really helpful when we use it in shared decision making with our patients to decide on therapies like statins and aspirins. And as well, I would think about other lipid lowering therapies, GLP-1s, etc. Aspirin definitely has a role to play for those 40 to 59 years of age, but they have to have an elevated cardiovascular risk. And again, using that advanced imaging can be very helpful for those folks, and always make your care personal as possible. With that, I think we are out of time. So thank you so much for your attention and for participating in this activity. To receive credit, please snap on that QR code there, and have a great holiday season. Hopefully you found this program helpful to your practice. Take care.
Thank you. Bye now.